Okay, thanks. Okay, so I'm going to talk a bit about something that, well, mostly things that happened in November 2020, which feels like it was about 10 years ago, but apparently it was only 18 months ago. And this is when we started the work. So this is work presented on behalf of a lot of people who will be named as we go along when I refer to some of the papers. Okay, so in November 2020, we started in Liverpool the MAST pilot, which stood for MAST Asymptomatic Serial Testing. Liverpool was in tier 3 of restrictions at the time. There were asymptomatic testing sites set up throughout the city, which were staffed by military personnel. And this was basically just for the month of November. In December, Liverpool moved from tier 3 to tier 2, which was a slight relaxing of restrictions. The testing still happened. There was a handout. The military sort of withdrew, and there were fewer test sites from December, and we moved from MAST to SMART, which stood for Systematic, Meaningful, Asymptomatic, Repeated Testing. So during MAST, the focus was very much on just everyone come and get tested, have a lateral flow test. SMART was more about focusing on testing in specific cases and talked about test to protect, test to release, test to enable. Okay, so the work we did, and there's various things that have been done in Liverpool, and have all mostly been enabled by this CIPHA platform, which stands for Combined Intelligence for Population Health Action. So this was set up across Cheshire and Merseyside to help the healthcare system manage the crisis. And it's a health management platform set up as a collaboration with the NHS, local government and the university. And basically it's a near real-time person level linked data set, which includes demographic, health information, test results, some information on medication and things. So in this case, the example I'm going to talk about, we're using it for mostly for the test results. So if someone had a lateral flow or PCR test in the Cheshire and Merseyside area, that information would be in this data set within the day. And we could access that data in a pseudonymized form. So the data sets, various data sets which we could link using pseudo IDs. So we didn't have access to the identifiable information. Okay, so what I'm going to focus on is the QA study we did as part of the asymptomatic testing during November. So we invited some people who were attending the testing sites between the 8th and 29th of November to take part in this study, where they would be swabbed for both an LFT and a PCR test. So the 48 test sites opened, the recruitment moved around the 48 test sites. There were up to 2 days recruitment in each test site, or 200 participants. And we limited it to 200 participants per test site to try and get a geographical spread across the city. So the PCRs were sent to Lighthouse Laboratory, and the military personnel who were at the sites would process the LFT sample. Okay, so what we then did was we looked at the LFT versus the PCR. So there were 5,869 total tests that total pairs of tests that we looked at. And well, you can see the numbers there, but we ended up with an overall sensitivity. When we say sensitivity, this is obviously, as has been discussed, it's against the PCR positivity rather than against what we might be more interested in, which would be infectiousness. But we found a sensitivity of 40%, and high specificity. There were only a relatively small amount of positive cases. So we had a total of 74 positive cases on PCR and 33 on lateral flow. Okay, so we also looked at this broken down by categories of CT values. And we've also got this row looking at approximate viral load. This was based on, I mean, obviously there are issues with translating CT to viral load, but these were what we used, and basically showed that the sensitivity increased as you, or the cumulative sensitivity, if you look at the bottom row, did get better as you excluded the high CT values. With the very high CT values of over 30, with none of them showing up as positive on the lateral flow. Okay, so this is just a graphical representation of that, showing the increase. Okay, so just before I go on, just a word a bit about the data flow. We actually had 4 statisticians working on this at the time, and it was all happening very quickly. And clearly that might seem like overkill because there were, it's not especially complicated statistics, but a lot of it was actually, although it was great that we had all this data coming from CIPHA, we didn't have a nice neat data set with the QA study. We basically had to go into this data flow and match people based on pseudo ID and times and locations to identify which ones had these matching LFT and PCR tests that were taken at the same time. And this did, there were some issues with that initially, where we'd had participants who'd had multiple pairs of tests who were included in our results, and that we had to then exclude, which wouldn't really make a difference to specificity because there was lots of negative tests, but with the small numbers for positive tests, if this was the case, could impact on sensitivity. So we ended up with the final results, which I showed you, where there was only 1 pair of results per person. Okay, so preliminary results initially were on the 25th of November. So this was, as this was still going on, we had some initial results which were reported to SAGE on the 25th of November. The sensitivity we'd come up with at this time was 49%. That was on a smaller data set, and with some, there was still some work to be done on. But based on these preliminary results, the Liverpool Health Protection Board at the time, which had planned to use negative LFT tests to allow visitor access to care homes, then paused that, and that didn't go ahead because of these initial results that went to SAGE. And there's a link there to that interim report. So the interim report then on MAST was published in December 2020 on the University of Liverpool website. There was a full evaluation on the whole SMART pilot in June 2021. And also in June 2021, the paper came out in the BMJ on this, the QA study, the performance. Okay, so our overall conclusions from this were that we wrote in the paper was that lateral flow test could be a valuable tool in combination with other health protection measures in identifying people with higher viral loads who are not showing symptoms. And then we had the sentence, policymakers need to consider the utility in context-sensitive ways regarding population levels of infection, phases of epidemic curves, and the transmission risks and consequences in specific settings. So we've tried to sort of be, balancing it, but but this 40% sensitivity and the initial SAGE report with 49% sensitivity is what was really picked up on in the media and on Twitter, and and that was some of the there was some some of the initial stuff that came out when the interim report came out in the BMJ. There was talk of safety of lateral flow test questioned after referring to mishap cases. It's also picked up in the Telegraph, and then there were responses in the Guardian. So there were a lot of discussion with this about this at the time. And I think in hindsight it was difficult to. We talked about the sensitivity, and as Tim has already discussed, if you're talking about sensitivity of lateral flow versus PCR, you're talking about sensitivity to detect a PCR positive test and not an infectious case. Clearly, even with low CT values, the ones that are likely to be more infectious, it looks like we would miss some cases. And we didn't detect cases at all with the very high CT values. So, I think everything was focused on the sensitivity of 40% at the time, which I guess was not the right headline message. And there was another study at the same time that was used where they're looking at the Birmingham students who were tested around Christmas that year, I think. There was 8,000 of them, and only 2 positive LFTs were found. And then when a sample were retested with PCR, they found some additional PCR positive. But the ones that they found, the additional PCR ones they found, did all have these CT values of greater than 29. So that was consistent with what we found as well, was that the really high CT values we weren't finding. We weren't detecting on the LFT. Okay, that's just an example of one of the things that came out around the same time in late 2020 about in the Schools and Colleges Handbook, which I think shows the difficulty of getting these messages across. It said that they're trying to be as accurate in identifying a case as a PCR test, specificity. And I think if you don't really understand what specificity means, if you're reading this, it's not clear exactly what that means. Also says the tests have lower sensitivity, but they're better at picking up cases when a person has higher viral load. That could, I guess, be interpreted as better than when they have a lower viral load, or does that mean it's better than PCR test? Anyway. Okay, so obviously as well, it's not just about accuracy in MAST testing. And we also need to think about, what factors would support uptake. Obviously, people have to take the tests, and as Tim highlighted, people, there has been a surprising amount of people who are happy to take the tests. But so in different contexts, this is other work that was done by colleagues in Liverpool. So a couple of studies, one in very different contexts and for different reasons, but one study, twice weekly testing of care home staff, showed only 9% of staff had at least 75% adherence to this testing protocol. But then in a sort of in one of the test to release studies, which is in press at the moment, there was 93 to 97% compliance with the testing regime in terms of daily testing to be allowed to return to work. Okay, so just some other work we did around this time, looking at social, inequalities and uptake of the MAST and SMART program. It's led by a colleague, Mark Green. What we found there in terms of uptake was that uptake was lower in areas of high deprivation, areas further from test sites. So this was around the MAST testing, where we had all these test sites around Liverpool, and also areas containing populations less confident in using internet technologies. So just going to show a couple of maps from this. This is some work that Mark did at the time. So towards the end of November 2020, when they were moving from MAST to SMART, they called it the Super Saturday and Super Sunday, which was where they were trying to get everyone to come and get tested. And Mark was asked at the time to give some feedback on where new sites should be opened temporarily for that weekend to try and increase accessibility. So this is a map of the existing test sites, and these areas are 15 minutes walking distance. The blue areas are 15 minutes walking distance from a test site. So you can see there's a gap in the middle here. And this is a map of the uptake that we had of the testing. And the sort of yellowish ones are low uptake. So you can see that this sort of coincides with the low uptake in terms of the walking distance. There's another area, there's another gap here down in the south. And that doesn't really have the same issue of low uptake, but that's a much more affluent area than this area. So I suspect that people are more likely to drive to a test centre from this area. Okay, so the map on the left-hand side then shows what, given the options for where new test sites go, these were the ones that were recommended by the modelling that Mark did for the green to try and fill in some of the gaps. And on the right, the red dots are where they actually opened the test sites, including in areas which were right in the middle of areas, very close to existing test sites. And this was just basically by the recommendations came in, and then the local government, councillors and things would sort of lobby to have more test sites in their areas. So just shows that, though you can try and improve these things, then sometimes it won't happen. Suggest new sites, yeah. So, and the new sites were not in the area where the gaps were. Okay. Okay, so just to finish, this is just some of the overall uptake that results of the 6 months that we had this MAST and SMART program. Over that time, 57% of Liverpool residents took an lateral flow test at one of the testing sites, with 27% of them actually having more than one test. And there was a 2.1% positivity rate for these lateral flow tests. So 6,300 individuals over that 6-month period who went for an asymptomatic test had a positive lateral flow test. And in the same period, 22,000 who had symptoms, which was 15% of those 15% of those tested positive. Okay, and finally, just to highlight some work that was done. So one of the things that colleagues have been trying to do was trying to establish, did this actually have any impact on, on things like hospitalisation? So there's a paper that's a preprint at the moment where they've looked at a synthetic control study to try and somehow quantify the impact of this program on hospital admissions. And what they've got from that is, I'm not going to go into the details of the methods for this, I wasn't directly involved, but they've estimated a 43% reduction in hospitalisations in Liverpool compared to control areas for this during this initial period of intensive military-led testing, and an estimated 25% reduction over the whole pilot period. But just finally, to highlight that about this CIPHA data flow, although it has its difficulties in terms of getting actually dealing with the data that comes in and get it in the right format. Yeah, the national data on hospitalizations in order to do this work took almost a year to obtain, and the CIPHA stuff we're getting almost on the same day. So it just highlights the importance of the data flow in getting this. Okay. So obviously this was on behalf of, I've put the references in for the co-authors. I want to specifically acknowledge these Mark, David, Marta and Ian who have been involved in producing some of the slides that I've used for this presentation. Okay, that's all. Thanks.
We have 6 minutes for questions. We finished early, yes, at the back of the end.
Hi.
Very interesting. I would like to pick up that sensitivity.
Yeah.
Because there is evidence now from Austria that if you use LFT testing by a GP, then that sensitivity jumps up to 89%.
Against PCR on the same time, yeah.
And the whole concept being that you test early at the time of infection, which agrees with your lower CT value and higher viral load. So you have increased sensitivity. I think it was about 90% in that sense.
It was about 90% for very low CT values, but that was based on only, I think, 11 people. So, yeah.
So I think it's important to continue this discussion because I think I agree with you that how we say this is important,
yeah,
and we shouldn't be abandoning it.
Yeah, absolutely. Right.
So thanks, I'm going to cut the other part of that, which is if you're doing a lot of asymptomatic testing in a large low reference population, is there a risk that quite a lot of those ICT are going to represent either antigen contamination or non-specific protein? So there's the tail end of PCR before we're actually getting the lateral flow tests is say lateral flow tests that we've got the same outcomes.
Sorry, I missed some of that.
So it's the point being that if those kind of CTs by the time you're getting out to the CT report, that's less than one volume in the 2 basis of viral transport.
Yeah.
So many of those are going to be where you have very small incidents of contamination in the lab, or where the probes are breaking down the assay. And if you're getting lots of those in a liver population, that's going to be a significant number of those positives. So I'm just wondering whether what we're seeing is that the lateral flow test is just not out.
I guess that's possible, I guess, yeah. I mean, I don't know enough about what's going on in the labs, I guess, to really answer.
Sure. I think one of the issues about the lateral flow tests is that the self-certification was sensitivity for detection of infection and not asymptomatic testing. And also when the MAST started, the prior expectation of the government had been that 75% of the citizens would turn out twice weekly for screening. And those were in a sense fanciful. And so it was extremely good that the Liverpool team did that PCR NFT dual testing. I mean, it was really good. And opened the way to the discussions about infectiousness, which might have been in the minds of various people who were initiating the system, but were certainly not clearly enunciated to the public. Yeah,
and that, yeah, absolutely. I think that's a good point. That it's, but in the long term, although it was difficult at the time because we didn't get the results we necessarily expected when we first did it, and then it got out there, and then there was all this discussion. But I think it's probably in the long term didn't do any harm.
I got a question.
Yeah.
Do you think across the pilot program, the interaction between the community, academia, health board, local government, do you think much has been learned in terms of what's successful in terms of getting the community buy-in that you need to? I mean, other than obviously putting testing centres where people are, what has been learned that's been a positive thing?
I don't know. I mean, I think a lot of things have been, it's, a lot of this was done, just very quickly and on the hoof, and there was a lot of learning, I guess, along the way in terms of the interactions. Yeah, I'm not sure if I can come up with any specific. Maybe we can discuss a bit more afterwards. But
yeah, can I add to that? I mean, I think this is a major question about the role of public health. Regional public health doctors, local public health doctors were not, in my opinion, very much involved. Not a public health physician, I'm an PhD physician, but they were not involved. And the question about risk assessments. Who's this one? In terms of the risk of lockdown versus the pains of lockdown versus the risk to victims because of no lockdown, that is a public health doctors about trying to protect the rest of the population, and politicians trying to protect the economy. And that they're both legitimate issues. I don't think that discussion is very mature in the first year. And I think that's one of the main lessons I think about. There wasn't a sensible way of discussing.
But there's also protecting the population as a whole, from not just from COVID infection, as well as from well-being and all that.
We're coming up on 25 minutes, so I don't want to have to carry both of you out. We're right out of time for this session, unfortunately. We do have Girvan around in the break.
Yeah, I'm around.
So let's thank all of our speakers for the first session. 11:45 to start the next session.